So obviously we are here to do a little bit more discussion around glaucoma, especially early intervention. This is obviously a hot topic and something that we are all very passionate about up here on the stage. So we're going to try and just keep this interactive amongst all of us guys so that it won't be too stagnant and we can have a lot of fun and hopefully have some fun discussion. So this is the panel that's up here. Myself from Barnett Delaney Perkins outside of Phoenix. You guys want to introduce yourselves? Sure. Mary's next.
Hey guys, I'm Mary Q. I'm at Cleveland Clinic.
I'm Eileen Bowden and I'm at UT Austin.
And I'm Manjul Shah. I'm at the University of Michigan.
I'm going to hand it over to Mary. So she's going to do our first discussion of beyond IOP, so looking again at early detection and treatment.
Great. So this is just an overview about why early detection matters. We want to prevent vision loss and improve people's quality of life. So earlier detection allows earlier intervention to protect the remaining vision and improve quality of life. Early detection also lets us tailor their monitoring and treatment plans. This promotes an opportunity for having individualized care plans, not a one-size-fits-all, and access to a wide range of available treatment options, and a better chance for winning the game long-term for long-term pressure control. Early detection also matters for reducing the drop burden. Up to 60% of patients don't take their eye drops as prescribed, so if we can detect them early and give them some options that don't involve eye drops, that might be helpful for their lives.
But I always think about the fact that, like, if we're starting earlier, then,
you're precious.
then there we go. There we go. Give you time to take a sip. If you're starting earlier and we're doing a good job with our diagnostics to identify patients earlier, then our game is actually harder, right? Because now this set of eyes and the human they're attached to is under our watch for an extra decade. Forget the fact that people are living longer. We have to come up with strategies that move up the algorithm, much more. And that now we're having just very different conversations about how we manage these folks. So,
And I like that Mary also talked about, the early detection. How are we doing early detection on this panel? Because I think that's an important discussion. I saw some really surprising data on how little early detection is being done in a lot of clinics. So it's kind of interesting to discuss like our treatment plan and protocol.
For me, a lot of my patients come to me referred by an optometrist in the community, so I think a lot of the early detection is happening with these local optometrist or comprehensive ophthalmology doctors. A lot of them actually just getting detected at like lens crafters, which is great. We just need to educate everybody out there about what to look for. And I always tell the people who have been detected early, like, congratulations, you're so lucky that this got caught while you have no field loss and you just have a tiny bit of cupping on your nervo CT. Like, this is great, we're gonna keep you seeing forever.
Yeah, I agree. Same story. A lot of the patients are referred to me already with a diagnosis. I have the luxury as a glaucoma specialist of getting all the testing that I want, when the patient arrives. So I definitely get OCT on every patient. Once they're a glaucoma suspect, I get that every year, even if they don't have any signs of disease. And so I definitely get the full exam, including visual fields and OCT at that first visit. I also think that engaging with your community, like you said, engaging with the optometrist, comprehensive ophthalmologists in your community, but particularly the optometrist, and just having them feel comfortable referring patients to you early on is an important thing. We have good evidence to show that aggressive treatment early can help prevent progression, even things like early SLT, early intracameral drugs, and early MIGS, early trabeculectomy sometimes if in the appropriate patients. These are very helpful in maintaining that 20, 30, 40 years that we talked about.
I wanted to chime in about what you said about now we have all these patients in 10 extra years that we have to watch everybody, and like, who is going to watch all these patients? There's not really enough of us, which is also sort of a plug for a healthy relationship with optometry. A lot of times patients might see me once and then we have a conversation and then we decide we're going to monitor them, and they can do that with my non-operative optometry partners, and we just have a close relationship where we can message back and forth. Oh, if there's a concern, you can send them back, or if this progresses, you can send them back for SLT or whatever. And so I feel like it's important for us to remember that we can't necessarily do every single patient's every single monitoring visit from the beginning to the end. And if we just lean on our colleagues and each do our part, then we can take care of all these patients for 10 extra years.
And all the sort of toys and tricks and stuff we're going to be talking about, the cool thing about glaucoma therapy in 2025 is it is no longer exclusively the purview of the glaucoma specialist. In fact, it is well established that, at least in this country, most glaucoma surgery is done by non-glaucoma specialists, right? And I would include MIGS in glaucoma surgery. It is, of course it is, right? So most glaucoma surgical care is being delivered by non-glaucoma specialists. And that is the only way that we're going to keep our head above water. So it's really nice that with these tools, we're kind of democratizing glaucoma therapy. And it allows us, if we think of glaucoma as sort of a pyramid, we have this base of mild, moderate, kind of folks, and we have the tip of the pyramid is like that 1%, that 5% who need big, nasty surgery. The same providers and the same algorithms can't serve all of those folks all the time. So we have to kind of rethink how we approach all of this. Again, especially since we're moving that initiation of therapy and identification up.
Totally agree. And I think that also, again, the relationship that you create with the optometrist also helps for better referral to you for procedure and then back to general care with them, which frees us up as surgeons to do what we do best, which is take care of people in a procedural way. With that, Mary, you want to finish up?
We're going to move on next to this case discussion. This is my current glaucoma fellow at Cleveland Clinic, Sam Goldberg. She's going to come up here and present this case so that we can discuss it.
You get the podium.
All right, welcome.
You're big time now. Let's go.
Just the green. Yeah.
Hi, everyone. I'm Sam. Okay, so this first case is a 62-year-old female who came in 2016 and had 20/20 vision in each eye. Her pressure was 19 and 20 on 0 medications, except for an oral beta blocker. And her gonio was wide open OU. You can see that she has a bit of cupping in both eyes. So here's her initial imaging. We can see that on the OCT optic nerve, there's some superior thinning in both eyes, as well as some borderline inferior thinning. And her visual field shows maybe an early arcuate or step in the right eye and just some nonspecific defects in that left eye. So at this point, we thought the patient was diagnosed with normal tension glaucoma, and we did want to offer her SLT as an initial management option. However, the patient was very against any type of intervention, even laser procedures. So we gave her latanoprost OU as a first-line agent, but as you can see over the course of this year, she had a lot of intolerances to basically every single drop. So she was switched several times to many different medications and ultimately landed on Zioptin, which she continued in both eyes. So next in 2017, she finally did agree to do SLT in each eye, and this is what the OCT optic nerve looked like at that time, which was pretty stable compared to the first year we saw her. In 2018, the vision decreased a bit in the left eye due to a cataract. Her IOP was 16 in the right eye and 20 in the left eye on 1 med, so it was still similar to what it was at baseline. And there was this pretty significant progression of the visual field in that right eye, and now it looks more like a superior arcuate. And we switched to dorzolamide because of an intolerance to Zioptin again at this point, and we discussed the likely need for surgery in that right eye, but the patient was still very against surgery. So in the subsequent years, we switched around the drops a bit. Again, in 2019, we added Repressa. We again talked about surgery. She again denied or declined any type of surgery. In 2020, we started her on an oral Diamox, and we added timolol. And then in 2021, because she was bothered by the cataract in her left eye, we did a phaco and Trabex goniotomy in that left eye. So here's just a nice graph of her pressure pressures over several years, and you can see that the pressure fluctuates between 10 to 20, and most recently in 2025, it's about 12 in the right eye and 15 in the left eye. And in 2024, here's her OCT optic nerve, and it looks somewhat stable to what it looked like initially in 2016, and same with her visual field. It looks actually pretty stable in that right eye on 2 medications now, and the left eye has this sort of possible inferior arcuate, but it's not quite specific to glaucoma, and so we're still just chugging along, trying to keep her pressure good on drops because she's still really hesitant to have surgery.
All right, that's a great case, and I think seeing the struggle of the medicines is very similar to, I bet, all the struggles we see all the time. So here's the question to the panel. How tolerant are you of many intolerances to medication? Because this is changing, right? When we all trained, at least me, okay, maybe I'm aging myself, but when I trained, it was trab, tube, drops. Those were our options, or SLT, which wasn't touched very often. Now we have all these other things. So how tolerant are we of intolerance to meds?
I'm definitely not very tolerant of intolerance to meds. I mean, I've seen so many patients come in with red, puffy, itchy, boggy eyes, and I feel so bad for them that they've been struggling with this for years. A lot of them just say, oh, this is just how it looks. It's okay, I'm dealing with it. I'm doing my drops like I should. And now we do have so many more options. It seems like at this time, maybe like a Duresta wasn't necessarily discussed because that could have been an option if she was well controlled on a PGA, but maybe had some issues with preservatives. We just have so many options now that I would hate to cycle somebody through a dozen options before moving on to something non-topical drop based.
Mm-hmm. Yeah, I agree. We have a lot of options now. So even in my time since training, my perspective on this has changed, and I have become less and less tolerant. Sometimes I'm less tolerant than the patients are. I am looking at the slit lamp at their eye, so I can see those microscopic sometimes changes that I know will eventually develop into something, pretty bad. Also, though, age can affect this. In a young person, I feel like I'm definitely much more intolerant. If I have a patient who's like 102 years old and they have a little bit of intolerance, but we know, they really just need all these drops to help them avoid surgery, maybe I'll let it go a little bit more.
So, I mean, the few notes, great job, Sam.
Yeah, great job.
Awesome job with that case. So the few things I think about, number one, we're in an era now where we can clearly see that for so many patients, the cure is worse than the disease, right? Do patients, are they aware of their glaucoma? No, they're aware of the side effects of their topical agents, unequivocally, until and unless it gets really bad, right? So we have to do better. Nowadays, especially in the post-light trial world, it's getting a little feedback, so sorry about that. I don't give my patients a real choice. I don't think starting drops versus starting with SLT is an equivalence. There is clearly superiority to the latter. And I press that, and I think patients want to know my opinion, not just, hey, here's the menu, do whatever you want. They come to us for our expertise as eye care physicians, and we understand that there's really big differences. In light trial, we know, right? The folks who started with SLT did better, and even at 6 years, the ones who started with SLT did better than the ones who switched over to SLT. So getting them in the right place at the right time makes a difference, and indeed is disease modifying. The other thing I think about with that patient is we got to look outside the eye. So she was on an oral beta blocker, and how many folks have we all seen who take that beta blocker at night? They're nocturnal dippers, their systemic blood pressure is dropping, and that's the cause of their glaucoma. So again, I think a big part of this concept of interventional glaucoma is the idea of not being passive, of being actively engaged in all aspects of care, whether it's the ocular surface, whether it's early diagnostics, whether it's looking at the systemic interactions, and trying to use all of these tools to kind of really be patient-centric and specific to the specific disease and the lives of the patients in front of us.
That's right. I think Manjul did my entire portion of the presentation, so thank you very much. No, I mean, I agree. I have, over the last decade that I've been doing glaucoma therapy for patients, I get the pleasure of keeping these patients for many years and seeing them back, especially when they abscond from care. They don't come back 3, 5, 6 years. And I'm starting to shame myself on those that I didn't intervene, because those patients do better. And I can see it actively. COVID was the biggest, I think, eye-opener for me, of patients who didn't come and see us for a very long time and they progressed. And somebody who had something as simple as an SLT really just had a lot less progression. And we have enough data to support that. So for those of us who, answered, over half of you, that SLT isn't first, my goal today, if anything, is to say SLT really should be not even offered first, but told that is first line. And it's really because we know it is superior care for them. And especially we know patients don't take their medicines. They don't come back to see us. We know all of that. And so something as simple as SLT is so effective for so many patients to keep them from losing quality of life. That's the most important. Because that's really what we're doing, is trying to save the vision. I don't care, a pressure reduction of 20%, great. But it's really holding onto the field long term is my major goal, and that's what I'm trying to do. And so whatever means possible, and with that, I've become much more interventionally aggressive. And I think that that is the best way to go, because again, I just continue to see it every day. Of those that I didn't intervene, I'm kicking myself. So in my practice, I now tell all of my referring optometrists, if they haven't had an SLT, get them in. Because we should at least have one throughout somebody's lifetime, if not something more than that. Yeah, Mary.
I think sometimes a limitation to offering SLT is like your clinic just might not be set up for it, like logistically. I now do all my SLTs on 2 Friday afternoons per month, and by I mean Sam does all of them. And so we have this thing set up where we have this laser clinic, we have 20 slots, and I picked those 2 Friday afternoons per month because it happens to be the day of the month where nobody else is operating or in clinic that day, so all the trainees are available to join me. And so over the course of the month, whenever we see any new patient or any established patient who needs pressure lowering, we always just say, like, would you like to have this light pulse therapy procedure in the office? I got that phrase from Emily Shaline, and it's really actually done wonders for making it less scary for patients. And so we just say, we can offer you this in-office light pulse therapy. It takes 5 minutes per eye. And a lot of people go for it, and then we just schedule them into this procedure clinic. And then on that particular half day, it's a very efficient way to treat a lot of patients. And we don't have DSLT, but even the regular SLT, I have found that just consolidating to having a laser clinic seems to be a more efficient way to offer this procedural care, rather than what I used to do before, which was just do them as they come, or maybe schedule one per session or something like that. I was wondering how you guys structure your SLTs.
I do the same thing. I have a laser clinic that I can just go through them very quickly. I think another thing that's helped me is I just see them 6 weeks later. I don't know if anyone still does like post-laser week 1 or any of that. That was something that I was taught to do, but I've quickly stopped doing it because I don't think it's necessary, and I think that also helps save some clinic time.
Absolutely, yeah.
And patient experience. They get really disappointed coming in and it's 2 weeks, 3 weeks post, and they're not seeing a pressure drop. I'm now waiting 8 weeks.
Yeah.
And for DSLT, if anyone has that out there, maybe even up to 3 months, that it really takes for full effect, just to let you know.
And I always offer both eyes on the same day. I know that you can only be reimbursed 50% for the second eye, but for me, we're just limited by the number of slots. So if I have 20 slots to work with, and if I can treat 20 patients both eyes, for their 6-week post-op, they go back to their referring optometrist. And so this is just a really efficient workflow for the patient and the referring doctor, because they know they can refer for SLT, get both eyes done that day, and then go right back to their local satellite where they came from.
I saw a hand up in the back. Yeah. Sure. Yeah, so I've flipped mostly DSLT purely for efficiency. So I have at this point doubled the volume that I do. So I also do, like everybody else up here, I do a laser clinic. I think it just makes my flow much better. I'm all about efficiency and using my time as appropriately as I can so I can treat the maximum number of patients, and that just helped me there. So I've gone from Yeah, I've doubled it at this point now that I've got a nice flow going in my OR. But if you have more questions afterwards, please feel free. I don't want to skip this because I know we need to move on, but I think sustained release is the newest, most exciting therapy that we really have available in glaucoma. And it really jumps over the barrier of compliance. And so this is my next go-to step. So after SLT, somebody's still not as controlled, reach for the Durista. For those of you who haven't tried it yet, give it a go. I use it in clinic. The patient is still just sitting up in the chair. I actually do it without even the slit lamp at this point, as long as they're pseudophakic, bilateral. It has been a real game changer. And this also gives patients kind of the taste of what life without medicine is like. And then they start to really realize this is something they want to use moving forward. And that can help you kind of move the needle towards maybe the operating room for something that is more permanent. But this has been a really, really nice way to give people a holiday, but still know that they're getting treated medically.
And the efficacy is remarkable. I mean, the old phase 1, phase 2 studies were compared to the old Lumigan, right? So Lumigan 0.03, not 0.01, and it was at least as good, right? So we're delivering an efficacious product directly into the anterior chamber at the target tissue in a way that probably works more profoundly than just a topical agent. We're starting to actually see durable effect beyond what the kinetics would suggest.
Absolutely.
You know?
We're seeing a lower response with just millimeters of mercury. And then the other thing that we're very bad at looking at as glaucoma specialists and generalists is the diurnal control. And that's what this slide is. But really, it's something that it's another modifiable risk factor that we just don't talk about because we don't have great measurement of it. And this is, I think, just as big of a deal, if not just lowering pressure, is really getting control 24 hours a day. And you do see that with using Durista, with using iDose, something that's a sustained released 24 hours. So it makes sense, right, that we're getting rid of the compliance problem, but we're also helping with the diurnal control. And I think that that's going to only behoove us with all the things that we're talking about with IG.
There's a question back.
Yep.
Yeah.
Is there a reason you reach for Durista rather than iDose? Why play something that will last for 3 months or maybe for a year rather than something that will last for 3 years?
Yeah, so it's going to depend on where the patient's at with their particular spot clinically. If they're ready for cataract surgery, then I'm most likely going to reach for the iDose instead of a Durista. For what? For iDose? You can. It just depends on the patient. Some people need a little more coddling than that. We all know that, right? So some patients just need the little extra boost. Sometimes their eyes look terrible and I really don't want to go in intraoperatively. They're really red and irritated. I love using Durista in that space as well. Just let their eye calm down and then I'll go in surgically and take care of them. So it's kind of, again, a bridge or gap for me because you're right. It's a one-time use as FDA approved, and that's really how I use it because I don't want to start fussing with the endothelial cell loss issue. But yeah, it's a gap. For me, it's a really nice gap filler. Anybody else have a different way that they're using their Duristas up here?
Yeah, that's right on. And to your point about other sustained drug delivery technologies, and they will continue to grow, right? This is still a relatively nascent space. Having that, that kind of exposure to sustained drug delivery, having that exposure to being controlled without drops is a motivator for the patient. Now the patient is bought in. I think we see that with laser. We see that with Durista. And now the patient is bought, sometimes you're trying to unwind decades of kind of knowledge that, oh, glaucoma is treated with drops. Of course, my father or mother was treated with drops until they had surgery. And so there is a little bit of unwinding that needs to be done. And the beauty of having this robust toolkit is there's no definitive start with step 1, then do step 2, step 3. No. There's a toolkit that you can apply in various ways. So I don't disagree that iDose,
My patients will say, well, I tried that didn't work, so now you want to take me to the operating room and do something else?
but
From a marketing strategy, and also in terms of, we're as glaucoma specialists, we're looking for safe and effective treatments, effective being the key. And 3 months of IOP control for lifelong disease, to me, using Durista just simply doesn't make any sense, either from a marketing strategy or from a clinical strategy.
So it's certainly not 3 months. The kinetics of the drug will be about 4 months, and we're seeing durable effect to 6 to a year after. So it's certainly longer, and it does, again, create the opportunity to have conversations and unwind pre-built dogmas. And again, the sort of durability, the introduction to this sort of thing, I joke with my patients, there's very few 0% and 100% in medicine, right? But at least so far, 100% of patients receiving a Durysta, after getting the Durysta, say, oh, that's it? I swear to God, I don't understand how. They must have a memo. There must be some Facebook group or something. Oh, that's it? Now you build some credibility. It does work. We know we're delivering pharmaceutical into the eye. And now, again, the patient is bought into the same journey that we're on. So now when we start to talk about novel technologies like iDose, like standalone MIGS, which is an emerging space, and again, whatever the next generation of technology is, the patient is on board as opposed to being kind of nervous about what you're trying to offer.
Yeah, and with that, sorry, we're going to have to move on from that discussion. But I agree, 100%. So Eileen, you're up.
All right, so I'm going to start by asking everyone to pick up their keypads, and we're going to go through another question here. So how should SLT be positioned in daily practice? 60% say as a first-line therapy for most patients. So going up.
Good.
Some change happening here. So today, can I go back? Okay. I gave a little talk on practical tips in selective laser trabeculoplasty, and there were many take-home points, I think, from that. But the three that I want to point out today is that SLT, we have really good evidence to show that SLT is a safe and effective and perhaps superior first-line therapy for newly diagnosed ocular hypertension and open-angle glaucoma. The effect of SLT lasts longer than I was taught. I always heard the 2, 3, 5 years, but we have several studies now that show that it can last on average 5 to 6 years or more, and it can be repeated when needed. And so the use of initial SLT in a certain proportion of patients might delay or avoid their need for alternative glaucoma therapies and certainly things like incisional surgery, perhaps for their lifetime. So I'll go through a little case here. We have a newly diagnosed patient, a 51-year-old woman who's referred by an optometrist for elevated IOP in her left eye. She's treatment naive. She has no history of any eye drop use or eye surgery. She does have a family history of glaucoma. Her father required incisional surgery at a later age, had a bad experience with that, and it is something that makes her nervous. She's physically active. She loves to travel. She has a very spontaneous lifestyle. She's 20/20 in both eyes. Her pressure is 19 millimeters mercury in the right and a little more elevated at 24 in the left. Her gonioscopy is open in all quadrants with some moderate pigmentation. She doesn't have too much cataract, some trace nuclear change, and there's some pseudo-X material on the anterior lens capsule. Another thing that I did not point out on this slide, but she does have some mild-ish guttae on the endothelium. Corneal thickness is average, and she's mildly myopic. We're going to focus on her left eye since that's the eye with the more elevated pressures. She has some glaucomatous cupping of the optic nerve on her fundus exam. She's got some thinning of her OCT retinal nerve fiber layer, and the ganglion cell analysis, as well as the hemisphere asymmetry, shows the nice wedge defect below. And she has a corresponding early visual field defect and early nasal step in her left eye. So what are our options for this patient? We've talked a lot today about whether or not we'd start drops first on a patient like this, and I've tried to move away from that. It's a reasonable option, and it is something that I still kind of mention to the patients, even though I don't necessarily advocate for it. And she immediately said no to drops even before I said too much. She's, like I said, has a very active lifestyle, travels all the time. She did not want to carry around a bottle or multiple bottles. So we talked a little bit about Durysta and SLT. Is there any reason any of you would choose one over the other, or another option?
The guttae would make me nervous, right?
Mm-hmm.
Also, just as a jump on, but is it reasonable to do drops first? I mean, we keep talking about SLT first, and then every time we back off on ourselves.
No.
I do not think it's reasonable. It's not reasonable. We have too much data.
I'll tell you where I use drops first. When someone comes in hot, their pressure
Yeah.
is like 50. For what it's worth, there's no faster way to lower pressure than medical therapy, right? SLT takes 6-8 weeks to start working.
Absolutely.
Durista works pretty quickly though. So if you can have that patient have access, we know all the boxes are checked, then by all means, Durista makes sense. If there is a little bit of risk, stratification, whatnot, that needs to be done, then, I think you could make the argument that some degree of topical agents would be indicated. But this is edge case stuff, right? I think in the vast majority, we don't need that immediacy. We want sustainability, right? That means we want a therapeutic regimen that's going to work with the patient's life, and it's not going to impede their life. And I think laser and sustained drug delivery, choose your direction, choose your order. And I think we can individualize, but that's probably the way to go.
I think there was a question.
So I come to this as a cornea specialist who I've just seen this prostaglandin orbitopathy in these eyes.
Yeah.
Finally the glaucoma specialist before who's now retired, but would send me these patients and say, fix their corneas. I just say they can't close their eyes anymore. And I tell my patients, and just correct me if I'm wrong, I just say this, we start with SLT now because it's safer.
Yep.
Yes.
Fair?
Yeah.
That's what I say.
Safer and more effective, right? We have all that data to support that they're not, I just tell patients bluntly, they're not going to go blind as quickly because we have that data.
I say we used to start with drops, but now we start with laser.
Correct.
Absolutely.
Yeah.
I think we need to say something that direct.
Yeah.
Instead of just say we can do SLT.
I agree.
and drops, because I keep hearing that.
Yeah.
And I think I'm hearing that too much. Like, no, let's do
No,
SLT.
do it.
Absolutely. If you give an option,
Yeah.
they're going to pick the path of least resistance, which they believe is drops, which it is not. So yeah, you have to be direct. It's not fair to give somebody an option because you're the educated individual. And so again, if I go to a surgeon, I go to the surgeon because I want to know what they would do. And I think everyone in this room, if they had glaucoma, would not choose medication first based on what we know.
Do we give patients the choice of optical biometry or like ultrasound? We don't do that, right? We have these tools. It's not that there is no role for ultrasound-based biometry, but we don't give folks the choice. We know one's better, right? If it was my eye, if it was your eye, you want the highest quality, best, up-to-date way to measure the eye. So there's clear correlates there. It's not equivalent. There's
I
clearly
wanna
a difference.
add a devil's advocate thing, which is like not every patient is a good candidate for SLT. And sometimes when you say the message like SLT first for everyone, you may get referrals from your local referring doctors of somebody who has like uveitic glaucoma or angle recession or has PAS everywhere. And then you just examine them yourself and then determine, oh, for this particular patient, this is not a good option for you. I think we do sort of, most times I agree with the refer for SLT referral when I examine them myself. But, a couple times I might pick up on something and I say, oh man, maybe for you, actually, that's not a good option. But in that case, you presented it with pseudoexfoliation. So that's a clear winner for SLT. So anything POAG or secondary open angle, SLT should be first.
And speaking of the Goutte, we obviously didn't go with bimatoprost in this patient, but do you ever, say she was pseudophakic, would that change things at all? Do you ever put Durista in the sulcus or try anything?
It's an interesting, off-label kind of use. We don't have evidence necessarily to guide us on whether that is safe. So I would say let's be conservative with what is still a relatively novel sort of family of therapeutic interventions. But I think that is absolutely the way we should start thinking, right?
Yeah.
Like we need to start thinking, we got tools, we got a problem, and we have even understanding glaucoma is not one disease, it's a gajillion, and we have to kind of tailor our regimen, so.
And we have so many other options that
Yeah.
skipping the Durista because of the way the cornea looks, I think is pretty reasonable. Let's go on to,
Question for the panelists.
Yep.
Like, how many years of maximum follow-up do you have with intracameral Durista?
how many,
How many years of follow-up? Like for us to confidently say that this is effective and this doesn't harm the patient in the long run. How many years of follow-up have you done for these patients?
So the clinical trials done on, is that what you're referring to?
Yeah.
The data?
Not the clinical trials, in your own
In my own hands, I feel like I'm usually I'm at least getting 6 months out of the Durista. And then I do have people who sometimes will float further out than that to a year, and they have data up to a year and a half.
Absolutely.
Which I think is definitely available. You just have to watch them.
Yeah.
Because again, it's a slow taper of when that medication starts to taper off. But I do tell patients that that's coming.
Yeah.
And this is usually a reprieve to see how they do medication-free and what we can do to reduce burden. So,
and insofar as safety, right, which is another key consideration, we have very good evidence. Like we're not doing cell counts on every single patient at every single visit, right? So we're looking at clinical findings, but we have good data. Again, this is where we have data that guides us that one implant, which is what's FDA cleared, is essentially nil insofar as endothelial toxicity, and that implant will dissolve by, it varies from patient to patient, but by a year, maximum year and a half, that implant's gone. So now you are basically starting from scratch. There's no durable, lasting negative that we need to be monitoring for.
yeah, because remember that the trial was done where they were doing multiple implants, stacking one on top of the other because it was regimented. They had to do a repeat. So that was the reason for the endothelial cell loss being so high in the trial compared to probably in reality, which is now we know we have to wait for it to dissolve and use PRN, but that's not how it was created. So just as a warning. You ready?
Yeah, let's do it.
Do it.
All right, so let's dig in a little bit more to sustained drug delivery. And again, this is kind of new, even though it's not. I mean, I think AbbVie chose a really awesome time to launch this. There was this little thing, this little bug going around the world around the time that this was launched. So it took a little bit of time to kind of integrate. But fundamentally, sustained drug delivery for glaucoma is just so novel. It's just a different way of approaching disease. So we are still sort of contending with how do we integrate this into our toolkit. So it's very reasonable for you to ask these questions, and thank you for doing so. I'm happy to report that we have data being presented at this meeting showing longer-term outcomes of kind of the next generation of phase 3, phase 4 clinical trial data. But that being said, let's turn it over to everyone here. How do you think about sustained drug delivery in your practice? All right, so
I like these questions.
Yeah.
I feel like we should answer these questions.
I know.
What
It's a
number are you?
ooh, let's see. So
I think I'm a 4.
you're a number 4.
I think
Yeah,
I'm a 4.
that's kind of where
I think
am
I'm using
too.
it in adjunctive at this
Yeah.
point for the most part.
It's typically, again, because our data on SLT is so awesome for primary therapy, it's not my primary intervention, but it's right up there with number 2, second intervention before I start integrating topical agents.
Agreed.
If I can.
Me
Yeah.
too.
There might be patients who can't position well for SLT, for example,
Sure.
in which case perhaps a sustained release could be a better first-line option for patients in that circumstance.
So we'll play this is not my patient. I apologize, my video didn't work, but this is one of our good colleagues. We can turn the audio off so I can kind
And
of
I
describe.
like to do this on
Or we can hear Brian.
Or we can hear Brian talk. So basically, I like the idea of performing Durista. I typically do it at the slit lamp. And it just allows a kind of a familiar place for me. But you do want some degree of magnification. Coming in at the temporal limbus, and I typically don't do this with a dilated patient. So, but it doesn't really matter. It's kind of pretty easy to hit the anterior chamber. It's pretty big. We want to go about 2 bevel lengths into the eye before we definitively push that button. And we want to pause a little bit after the implant is released before we come out. I also like to kind of create a little bit of a corneal track as I enter, and it just creates a little bit more of a self-sealing needle entry. This is a 28 gauge needle. It's really, really small, and I'm not really worried about a leak. I am sometimes worried about that egress of aqueous that may come out, kind of drawing the implant out towards that needle track. The one thing that you have to be worried about with Durista placement is if that implant follows that pressure gradient and gets stuck on the temporal corneal endothelium, that can cause, obviously, corneal injury. It's easily managed. You can take a 30 gauge needle right through that 28 gauge track and just push it right back into the AC, and it'll stay. But it's sort of nice and slick if you just don't have to deal with that. So a little bit of a tunnel before I enter. I go 2 bevel lengths in, push the button, and we're good. And again, 100% of the time, patient says, oh, that's it. I'm sorry?
Could you replay, please?
Yes, absolutely.
Other tips is for those of you who haven't tried a Durista, the button, if you partially depress it and then do a firm secondary depression, that really flicks that Durista out, because every once in a while it can get trapped on the tip of the needle.
Right.
So that's another thing that I like to do. And also, if I ever have anybody where the Durista tracks as I am exiting the eye, if you just have them sit up and look at them 10 minutes later, it falls.
It often falls.
It always falls.
Exactly.
I've never had one that just stays.
So again,
So I don't manipulate.
I've literally had patients' family in the room, and the family member says, "Oh, that's it." So like it's like everyone in the building says, "Oh, that's it."
It's so true. They all say, oh, that's it.
Yeah, it's weird.
It is weird.
Yeah, I don't know if there's something coded into the implant that makes people do it, but it's really remarkable. So again, I think we've kind of touched on this a little bit, so I'm not going to belabor the point. But you know, this is an emerging space, and I would encourage all of us, again, as folks who care about our patients with glaucoma, to think about our toolkit and think about where we can. There's no dogma, there's no rule that we got to start at step 1 and go to step 2. So, you know, think about how we can integrate some of these technologies in. Yeah.
Do you usually use a speculum or no speculum?
I don't use a
I do
speculum.
not.
I find that to be more uncomfortable, so I just kind of, I use a sterile glove, and I just kind of hold the lid and tell the patient to just look at my ear, you know, like kind of how we classically will examine the posterior segment or whatever, just look at my ear. And it's a relatively, you know, so I don't like using the word quick, you know, because, you know, CMS is always watching. So it's a very efficient procedure when you do it that way.
It's like an AC tap or burping a wound after phaco, but in reverse.
Exactly. So we'll switch a little bit. You know, surgery is always the fun stuff. So let's go ahead and answer this. You know, MIGS is a huge, broad microinvasive glaucoma surgery, a broad family of ever-growing glaucoma therapeutics. How do you think about those in your algorithm?
That's interesting.
Yeah.
Go
So
standalone and early, huh?
that's great. Yeah. Well, you know, for the interest of time, there is you know, really great work that one of our colleagues right here on the panel worked on insofar as creating a consensus protocol. So please feel free to scan that QR and dig in. Or there's a couple kind of papers there. But we're going to skip right ahead to our cases and kind of use the algorithms in action, if that makes sense. Has everyone gotten their snaps? You can even take a picture of it.
And just know that this was a consensus by 12 different individuals, both general cataract surgeons, as well as glaucoma specialists. And we really sat in a room and kind of hashed it out about how we really wanted to treat people based on where they were at in the disease. And we really were talking about a lot about compliance, a lot about safety and efficacy, and that's kind of where we landed with where we did. So yeah, take a gander. I think really most of it is really also to help you have a roadmap and then provoke your brain of how you want to take care of patients. Because I've realized since being part of that and creating an algorithm, it kind of forced me to be a lot more regimented with how I treat patients. It's actually simplified a lot of my thinking.
And by no means is it prescriptive.
No,
but it
not
is-
at all.
And it's certainly guided. I think a criticism I get in academia is, where is the evidence? Like, okay, where was the evidence for trabeculectomy in 1969, a year after? Come on, no, it took us a long time to get robust data. But I would argue in the MIGS space, we are doing a really good job. We always could do better, but there is a robust data set across various devices, techniques, whether it's Schlemm's canal-based surgery, suprachoroidal surgery, subconjunctival microinvasive bleb-forming surgery like the Zen. We have robust data, randomized, controlled, single-arm, retrospective, prospective, any way you cut it. We have data. Obviously, we want more. Sure, we do, but we have it. So it's no longer an excuse to say that that's sufficient. So with that, let me turn it back over to Eileen to kind of discuss this case.
All right, so this is an 81-year-old woman who came in complaining of eye redness and irritation that was her number one chief complaint. And number two chief complaint was halos and glare, especially at night. She has a history of primary open-angle glaucoma, and she was treated with a lot of drops. She was on latanoprost, dorzolamide, timolol, brimonidine, and nitarsodil, and she hated her drops.
I do too.
I was going to say that. I don't blame her. That's a lot.
She had kind of what we've been talking about. She had this periorbital scaling, erythema, like a contact dermatitis in both eyes. Her vision was decreased, 20/40 in the right, 20/60 in the left. Her IOP was 17 and 20. Her maximum pressure in the past had been in the 30s, so 17 and 20 on all of those drops. Gonio was open. She did have some moderate cataract in each eye, 2+ NS, and some cortical change, OU. And she had some inferior and superior thinning of her nerves, more so in the right than the left. And these corresponded to field defects, nasal step in the left, and some more arcuate type change in the right in both hemifields. So here I kind of thought through my options and came up with reasonable explanations to myself to do almost everything for this woman, and anywhere from canaloplasty and goniotomy to Zen or trabeculectomy. The testing that she had done was actually pretty stable for the past couple of years. So the main thing, it wasn't that her disease was progressing, it really was that the medications had just become very intolerable. Do you guys have any thoughts on anything that you would offer in particular?
I think that's so reasonable too, though.
Exactly.
Quality of life is a new discussion for glaucoma. So for those of you who aren't doing it yet with patients, go for it. They're going to love you for it. And actually caring about their quality of life and how these medications are making them feel is a big deal. And the happiness post whatever you decide to do is also helpful.
Isn't it weird that we're talking about thinking about quality of life as something novel? Like, who went to medical school to lower IOP, to be a plumber? Anyone? No. We went to medical school to help people lead better lives. And we became ophthalmologists to help people lead better lives through their eyes. That's what we're doing this for, right? So if we're beating someone up 16 times a day, we're not helping that person. That person has to look through those eyes and navigate the world. We all have seen the consequences of polypharmacy and ocular surface disease. And again, as we talked right at the top of the hour, the cure, quote unquote, her glaucoma is controlled. The cure is worse than the disease. And this is not a sustainable, no one wants to live like this. No one wants to live, no one deserves to live like this.
Eileen, can you remind me whether this was POAG or a secondary open-angle glaucoma?
POAG.
I ask because when it is something like a secondary open-angle glaucoma, I get really excited about it. Like, I look so hard to see if I can just find any evidence of it. Like, I look in their med list and I'm like, an inhaler, like, you know, anything that gives me any clue that it might be something secondary makes me excited, because then a TM-based MIGS is going to just work extraordinarily well. You know, sometimes if it's POAG, it might be hard to get someone from 5 meds to 0, but if it's a secondary open-angle glaucoma, you can get people from 5 meds to 0 with like a hemigat procedure, for example. And so even with POAG, I would probably still do the same, like a phaco hemigat type of procedure. But if it is secondary, you can feel a little bit more confident about it.
I completely agree. So I talked to her about the possibility of needing to go back to surgery more than once, and she was okay with that. She wanted to do the least invasive thing. So we started with her left eye, her milder eye, and she did receive a phaco and an omni canaloplasty and goniotomy, and I did the full 360 degrees, and she is very happy, and this is her left eye treated eye compared to the right eye post-op.
Yeah, I love this. Like, when you look at this, which is the eye that just had surgery, right? Is it the right eye or the left eye? Which one, guys? Yeah, the one that looks better is the one that's been operated on. Oh my God, surgery's horrible. Guys, we got to reinvent the wheel. We gotta rethink this loaded term of surgery. Surgery makes people better.
This was about 2 months. This is now in pre-op for her other eye to be done.
I have another devil's advocate thing. One time I did a phaco GAT on a 85-year-old with pseudoexfoliation glaucoma and visually significant cataracts and like pancreatic cancer. And I was like, okay, great, I'll do your phaco GAT. You'll be off your 2 drops and you're going to have a good quality of life. He like does upside down yoga still. He was like somehow very healthy despite that one liner. And he was getting recurrent hyphemas when he was doing his like headstand yoga moves. And then I was like, darn, I was just trying to have you have a better
Don't
quality
tell them
of
the
life.
scary story, Mary.
No, it's important. Just like,
Fine, guys,
like-
if you have an upside down yogi.
Yeah, so now I ask everyone like, oh, do you do any, extreme heavy lifting or upside down yoga? And most patients are like, no. But maybe I'll do a hemi-GAT instead of a 360 GAT if someone has that kind of lifestyle. So I was burned by that one time.
And fundamentally, what you're alluding to is the fact that with a variety of tools, we don't need to be one size fits all. We can tailor our therapy. Again, we have our first principles. Our first principles is not lowering pressure. It's making people lead better lives. That's where we start. This guy probably values his upside down yoga time, right? I don't value upside down yoga time. So if it were me.
Yeah, I wish I had elicited that on his
Yeah,
history and I could have picked a slightly different
But
MIGS.
we can tailor, we can titrate, we can modify, we can be nuanced and not be kind of broad strokes and really, again, deliver the kind of care that folks need. Yeah.
Yeah, the classic one along these lines is no history of trauma, no history of trauma, are you sure, are you sure?
And then the lens is jiggling when you're in the operating room? Yeah.
No, but I've been a boxer for 50 years.
Yeah. I never got hit though. I'm a really good boxer. Yeah. Absolutely. We've all.
But the nice part is, again, like Manjul said, our toolbox is so big. So find something you're comfortable with and start it if it's something new to you, but then expand on it because it's really fun to be able to kind of play in this space and realize you've got, again, a lot of different options and that ultimately you can make a really big impact in people's quality of life and then also long-term, holding on to what we're all trying to do, which is quality of vision. So I think we've been really chatty.
Yeah.
Which has been
Well,
great.
so have you guys. So
yes,
thank
which
you.
is awesome.
Yeah.
Thank you. It makes it much more exciting. I know, but we're already an
There's
hour.
a really cool video.
Okay, we'll watch the cool
Show
video.
the really cool video. Get up here, Sam.
Go real fast. There's a really cool video.
gonna skip to the good part. Is there a clicker?
Yep.
Okay, basically this patient showed up with pressures of 18 on one med, and I'll just skip all this stuff. We started them on drops, we did SLT, but they had a visually significant cataract to them,
They had a visually significant cataract and they didn't like being on one drop. So we decided to go to the OR to do a cataract surgery and 360 canaloplasty in each eye. And while we were there, we decided to also put a Durista implant inside of Schlemm's canal because we made this little goniotomy at the beginning of the canaloplasty and thought, Dr. Q thought, what a great idea to just put that Durista in there so it wouldn't affect the corneal endothelium, would be out of the way, it might still be effective. So I hope here's the video. So we inject the Durista and then grab it with these MST forceps and just nudge it into Schlemm's canal, right where the little goniotomy was, and scooch it over so it's sitting nicely inside the canal. And then it just stayed there. And we did this on each eye, and we only have about 1 week of follow-up so far. And post-op day one, you can see post-op week 1 was 18 and 16 on 0 meds, and so far we only have week 2 in the left eye, and the pressure is still 18 on 0 meds. So we'll see how this patient does. Oh, and here's a nice UBM picture where you can see the Durista inside of Schlemm's canal. And there's some slit lamp photos as well where you can see the Durista there.
Don't worry, guys. That's not how you gotta normally do.
This was my first and only time trying it this way, but I thought it was kind of cool. She came in on 2 meds. She got SLT. She's on 1 med. She got phaco MIGS and a Durista in the canal for fun on 0 meds. And, it won't last forever. It'll only last 6 to 18 months, but I just thought this was kind of a nice story.
That's interesting. It is. It's cool. I like being innovative. I mean, now I think with iDose, I'm assuming this was pre-iDose.
Yeah, it just, I didn't really have that as an option.
Yeah.
But since I had this, I thought I would just try it, and I hadn't tried it before. It didn't crumble. Somebody said maybe it'll crumble. It didn't. It just went right in. So we'll see what happens. It's only been a couple weeks, so I'll just keep taking some serial pictures
Yeah,
to
I'll
see.
be curious to
Yeah.
see what the canal looks like
Yeah.
over time.